Hello, I'm David Piros, an internal medicine resident with the TIGMA residency program at Texas Vista Medical Center. Today I'll be discussing a rare presentation of tuberculosis, septic shock due to co-infection with COVID-19 in an otherwise immunocompetent host. Introduction. The progression of TB to septic shock has been primarily reported amongst the immunocompromised. A co-infection with COVID-19 represents an increased mortality risk and a confounding factor in diagnosing TB. Furthermore, similar symptoms between the two infections may lead to missed TB diagnosis. In this case, we describe a rare presentation of septic shock due to co-infection with COVID-19 and TB in an otherwise immunocompetent host. Case: a 64-year-old Hispanic male with a history of type 2 diabetes mellitus and hypertension was evaluated for complaints of worsening dizziness and generalized weakness with multiple ED visits within the past year for chronic cough, night sweats, and unintentional weight loss. He endorsed significant tobacco and alcohol consumption, but denied IV drug use. Physical exam revealed a cachectic-appearing male who was slow to respond with hypotension at 86/54 and hypothermia at 32.2. Labs were significant for anemia, thrombocytopenia, elevated INR, hyponatremia, hypokalemia, lactic acidosis, low albumin, and mild transaminitis. HIV testing was negative. Chest X-ray was significant for bilateral apical cavitary changes, with subsequent CT chest imaging confirming these findings. Sputum stained positive for acid-fast bacilli in cultures group pan-susceptible Mycobacterium tuberculosis. He was also found to be positive for COVID-19. Anti-tuberculosis therapy with rifampin, isoniazid, and ethambutol was promptly initiated. After the patient's respiratory status declined, he was initiated on systematic corticosteroids due to COVID-19 pneumonia. Despite this, his clinical status deteriorated, developing septic shock requiring pressors, respiratory failure requiring BiPAP, and transfer to the ICU. In this setting of profound encephalopathy and worsening clinical status, family members decided to forego additional CPR. His last chest X-ray and chest CT were taken just prior to the decision to initiate comfort measures. Shortly thereafter, he expired, 32 days after admission. Discussion. The novel coronavirus has a troublesome and exacerbating correlation to TB. For those with a latent TB infection, contracting COVID-19 could reactivate the mycobacterium, potentially leading to an accelerated, more severe form of the disease with the potential for multi-organ failure and death. Possible risk factors for worsened prognosis amongst COVID-TB cases have been previously identified, such as male sex, older age, dyspnea, hypertension, diabetes, leukocytosis, CT findings of bilateral lesions with infiltrates, and tree and bud appearance. Additionally, evidence proposes that co-infected people are twice as likely to develop severe illness or death compared to those infected with COVID-19 alone. Therefore, given the clinical parallels between the two illnesses, we recommend routine TB screening for all COVID-19 positive patients in endemic regions due to worsened prognosis of COVID-TB.